All right, we'll go ahead and get started. Today we're going to do a multimodality on the aorta, and I'm going to shorten my talk to some essentials, given that we're in a place where we have the benefit of both dynamic CT and superb CMR, and clearly we're using it a lot in assessing patients with aortic disease. When you finish and you go and practice, you may or may not have that luxury that we have here. So I still think it's important that you do have some knowledge about what we can do with echocardiography, because you may need to have that knowledge. Otherwise, you'll have to be sending us all your patients over here, which we'll be happy to take too. So I'd like to spend time on the imaging views by transthoracic and TE. Very important topic, which is the serial assessment of ascending aorta size, and you'll see why this is a very practical point of view. We'll talk a little bit about dissections, again, because TE is still the easiest technique to be at the bedside when you have a critically ill patient for a dissection. Again, we use it less these days because frequently many patients already have been diagnosed elsewhere, or because we can diagnose them rapidly now with the dynamic CT. Aortic rupture is a rare condition. I'm not going to spend too much time on it. You may go your whole life and not see a case. Basically, it's a pseudo aneurysm. And again, for the sake of providing more time to CT and MRI, I'm not going to spend too much time on that. And I will spend some time in aortic debris because, again, I think TE is still the gold standard for assessing debris in the aorta, in the ascending or descending aorta. So, talking about the views, this is your traditional parasternal long axis view. And of course, you see the aortic root, and you might get to see up to the sinotubular junction, and that's about it. If you're concentrating on seeing a good heart, that's about as much as we see from the aorta. And that's the view that 99.999% of the time our sonographers will get for us. Now, the other view that I would like to get everybody here, all the sonographers, to agree that this probably should become a routine view. It's a little higher up in the ascending aorta, and with a little bit of work, you can get that view in 90% of patients. Not always, but even sometimes clinically difficult patients, you're surprised if you work at it, you get the ascending aorta. And I'll show you a case later why that's important. This ascending aorta, as you can see, if we were to measure it, it's going to be close to 4, which is a little bit on an upper end of normality, depending on body size. And then the suprasternal gives us kind of the mid to distal arch, doesn't give us much of the proximal arch, but you get that curvature, you get the subclavian coming out, and if something is happening right there, you might be able to catch it. And of course, you can look at the size of the aorta. And then descendings are the most difficult ones, and to be honest, the best views probably are the short axis views, the same short axis that we used to look at the LV, but if you basically orient the transducer to be parallel to the spine, so you ignore, the heart is going to look very funny, but if you orient yourself parallel to the spine, then you may be able to open nicely the descending aorta. And then finally, of course, the subcostal view that gives you a look at the ascending aorta, abdominal aorta. So with the TE, again, the same story. In the traditional 120, 130 degree LV outflow view, you will see the aortic root. Here you see actually a little bit more of the ascending aorta. But if you want to really see a lot more of that ascending aorta, the 120 will foreshorten the aorta. So you get down to about 100, 90 to 100, the aortic valve and aortic root may not look as pretty and as good as they look in here, but you get a much nicer look at the ascending aorta. And you can pull the probe up until you lose the images because of air in the trachea. And that's the blind spot for TEE, which is somewhere in here where you may not be able to reach it from any angle, and that has been called the blind spot because if you have a very localized process there, like, for example, a tiny small tear, with a hematoma, you could miss. Then we get to the traditional descending thoracic, where it's basically you turn the probe around, and you guys all know it from doing TEs, And that's a pretty straightforward view. Now with the X-plane, you always get a very nice shot, and we can basically move up, and then eventually you turn and see the arch. And again, notice that you tend to lose a little bit of the arch around here. So this gets us back to this some spot around here that either between not being able to reach it using the 100 degrees or not being able to reach it from the coming back into the aorta, we might not be able to we might miss. And how the heck did I do that? Okay. Now, I want to take you back again to this view, and this is a nice example why I think this view is so important. What happened here? Okay. All right, thank you. This is a 55-year-old man that I've been following now for 5 or 6 years. He has bicuspid aortic valve. He has some AS that he still has not matured. He has an ascending aortic aneurysm. And he's had a couple of CTs before I ever saw him. Then I did an MRI, and he hated me forever because he's claustrophobic. And of course, Dr. Shah had him there for an hour and a half because he was doing a meticulous assessment of not the aorta, but also the aortic valve and everything else. And so he pleaded with me to have an open MRI the next time, which he did, had one open MRI. And then we discovered that we could actually see his ascending aorta very nicely by the views I just told you. And he has his last MRI was at 48 millimeters, and right here we can see exactly 48 millimeters. So the beauty of, if you can do this, is that, of course, you save the patient a lot of money, radiation with CTs, and even some of the discomfort of an MRI that some people have a lot of claustrophobia with. So, I mean, for an outpatient routine, once you have established sizing, once you may have done either one CT or one MRI, and established sizing, if you get a good view here, hey, you know, you have a nice way of following that patient and then deciding when you may want to repeat that MRI or repeat that CT. And the patient will really be very happy with that. So I really plead with sonographers, spend time learning and getting that view. It's a very important view. We can help them when we order the echo by specifying ascending aorta. Look at, because that way they know we want specific look at that. Okay, so that's one practical point that I like to bring. So dissections, you are in a place where dissections were classified by Dr. DeBakey, 1, 2, and 3, 3A and 3B. And Stanford then simplified it into A's and B. A's for ascending, B for the descending aorta, with the caveat being that the class 2 is just localized to the ascending aorta, where class 1 crosses the arch and the subclavian, and then could end anywhere here, or all the way down to the legs. Class 3 or B start after the subclavian and could end up anywhere. So if it's a small one, they call it 3A, and if it goes all the way down, it's a 3B. But as you know, the importance is that most of the time, this group needs immediate intervention unless they already, by natural selection, passed the natural history and then they're sent here late. But somebody comes in acutely, you don't know what they're going to do in the next 2 weeks. You have to intervene acutely because they do have a very high early mortality. Type 3s or Bs are treated usually medically unless they're showing signs of impending rupture and things like that. So with TEE, this would be a slam dunk, level 1, nobody argues. Notice, why is it that we see this so quickly and we know it's a dissection? First, we see a line that doesn't belong there. Second, we see actually 2 lines that don't belong there. And then we see that line is moving. But it's moving not in concert with the motion of the heart. So it has a movement of its own. And I think that, as we will see later, is probably the most important cue to have when you are looking for dissections. Here we are in the aorta. Here we have a type 2, which basically ends before the arch starts, before the descending aorta starts. And this would then be, hopefully, if it plays, I think a type 3, which starts after the subclavian. Okay? So this is clean, and then the dissection starts after the subclavian. False negatives. Can they happen? Yes. How often? If you know how to do TEs properly, very, very infrequent. Most recent studies show neck-to-neck sensitivities of TEEs with CMR and so on. Okay? Can it happen? Yes, it can happen. Most commonly because of the blind spot area. Very small, localized dissection, usually in that area that we discussed before. And then occasionally an intramural hematoma may be missed. Intramural hematomas are a little different because they don't have the flap that we talk about. It's a more of a inside bleeding within the vessel wall, and those can be a little bit more difficult to pick up. And in studies comparing TE with CMR, there's a suggestion that CMR may be a little bit superior to TE. But again, these are more rare lesions, but you have to be aware of them, particularly if you have somebody with the right symptoms. False positive is 99% of the time artifacts. Occasionally, if you have an aortic aneurysm with a thrombus, it could kind of look alike, but most of the time you can take care of that one. It's really the artifacts that can be a problem. Like this one, okay? So you see that thing jumping there. Is that a dissection? Okay? You know, it's very, you say, whoops, let's stop and look, because clearly that will catch your eye the first time you see it. So is it yes or no? Okay? So again, it goes back to what I said earlier. A real flap has an oscillating movement that is not related to the aortic wall. Artifacts tend to move parallel to the aortic wall. And you see that one there. Actually, the first time you see that, that is really very impressive. This one will make you stop and relook because, I mean, it's right there, flipping in your eyes, okay? You do an end mode, and now you can see that that linear structure is moving totally in concert with the walls, which is very typical of an artifact. This one is not actually as prominent as the other one, okay? And the first time you look at that, I can tell you, I would have to say, gee whiz, I don't know, maybe dissection, maybe an artifact. It's even less prominent. But look what happened when we go to the short axis view. Now we see that area there. And look what happened when we went to the arch. Okay? So again, you don't put all your eggs in one view. You look at the entire aorta because most of the time if you have an ascending dissection, it's going to end up somewhere. So this one is a type 2 that is ending in the arch, but now you can see that nicely, and you can see that nicely, and you can wrap it up. And you can see now that there is movement of that flap that is independent to the movement of the walls. The other thing that I have to remember that dissections don't happen in a straight line. In fact, they commonly go elliptical. So they start in one place, and they kind of roll around like this as they are progressing. And that's why sometimes in one tomographic plane, you'll see two flaps. It's not that you have two dissections. It's that you're catching 2 points of that elliptical rotation of the dissection, which when you do 3D reconstruction with other imaging modalities, or even with 3D TE, you can then very nicely pick up. Maybe, I don't know, Steve, do you have a 3D of that? That would be really cool. I don't have one. That shows the elliptical? Yeah, that would be pretty cool. So, you made a diagnosis. What else do you need? Well, actually, 99% of the time, what you need is a diagnosis. However, you do want to look at the aortic root to see if the aortic root is not huge, because if it's huge, they're going to need to replace that too and do more of a composite graft. Because otherwise, what you want to do is just put a graft in the sinotubular junction on, but spare the aortic root. You want to look for valvular problems, of course, if there is AR, severity and mechanism of AR. And then you want to look at sizing of the descending thoracic aorta, because both type 1s and type 3s, the descending aorta, the false lumen can enlarge to a point that could become a problem. And in fact, once you have treated the acute condition, either with medicines for a type 3 or with surgery for a type 1, what is left now is following up the descending aorta. The progression of that, would that patient do well? Would that patient eventually need a procedure down the road because the false lumen continues to expand, and then it becomes an expanding aneurysm with the risk for rupture, in which case then you have to decide whether stenting, surgery, or what. And that's a role, actually, that I want to leave time, because I know that Faisal may talk a little bit more about that for the role of CMR these days. One thing about the neck vessels, you can take the TE probe after you're done and put it right on the neck. I mean, just a simple thing. It's a probe. You clean it, put it here, and do a little carotid. And here's one. There's a flap. Now, it's all right. So he's dissecting. What are you going to do about it? I mean, it's not going to change the treatment. It's still going to do the same thing. So that's kind of a nice extra credit. But it's not necessarily that because you saw that you're going to do anything dramatically different. But it's very easy to do. To just take the probe, clean it, put a little thing there, and stick it in the neck, and scan the neck. And of course, pericardial effusion, very important. Pericardial effusion is almost like a kiss of death. Even a small effusion is an indication to get your butt and take that patient to the OR within minutes. We have seen catastrophes happen in less than 30 minutes. So if you see a pericardial effusion in any type 1 or type A dissections, it's not like, okay, call the surgeon at home. No, it's get the guy to the OR now. Because it really is one of the most impending disasters that you have in your hands if you don't act. All right, so there's a lot of color there, looks like a lot of AI. But the question is why? So what do you all think? Jeff, what do you think is the cause of the AI there? Of what? You got it. I was reading there, so it made it easy for you. I didn't look at that. We'll believe you. You look like an honest guy. Good guy from a lot. That's right. If you had just jumped at it, you would have been more suspect. So you played it well. That's right. And that happens often. It's that just the flap prolapses through the aortic valve and then, of course, impedes the closure and causes AI. Treatment for that is 3D dissection. Whereas if you did not have that phenomenon, and if you had a thickened valve and it's not closing well and the aortic root is now 5, now you have a different story, right? Now you have a situation where you have perhaps a combination of aortic valvular disease or aortic root dilation, and now the whole therapy of the dissection gets a little bit more complicated from a surgical point. Type 3 is, again, you make a diagnosis. Most of the time that's good enough for initiation of therapy, which is medical. And basically your concern now is for anything that may suggest that there is a rupture with a pseudo-aneurysm and a false lumen formation, which, again, is not common, and patients usually have a fair amount of pain. And again, if you do a good scanning of the entire aorta through the esophagus, and now with the X-plane, it's even easier. You can pick a point where, using color flow, you will see color going into a space that is outside the aorta. So it really is not that difficult a diagnosis, although it's a rare condition. You should be able to diagnose it. We've seen a few cases here, and we haven't missed them. Even though the first time we saw it, we had never seen one before, but it's so apparent that you see a color jet is going someplace where it's outside the aorta, it's a cavity, there's a lot of clot formation in that pseudoaneurysm and so on. It's not a difficult diagnosis to make. Other than that, basically you're going to treat them medically. So usually the chronic dissections are considered after 2 weeks because that's the time where most of the bad things acutely have happened. And when you repair a type A, you convert it into a type B. So it's the same thing. You're now following the aorta for late events, where now what you're interested in is progressive sizing of the descending aorta with the dissection, including the false lumen, to see if there is false lumen expansion or if there is false lumen healing. So as you progress and you follow patients, initially you're going to see them do something every 3 or 4 months, then perhaps later every 6, perhaps eventually. I have a lady I've been seeing for 20 years. She gets now a CMR every 2 years because it's been so stable. So basically, you space your serial assessment, and for that, I think clearly we have better imaging technology today. We could do TEs, but I think we have so many more things that we can do now with CMR and CT that I think I should leave some time for them to talk about it. And the last thing I want to talk, because this one clearly, I think is clearly one where TEE has the big edge, is looking at atheromas in the aorta. This is the traditional classification. Grade 2s are just basically thickening of the wall. Grade 3, now you have a greater thickening and you have some level of irregularity. Grade 4s are just huge chunks of plaques that even a fellow in day 1 of TE would not miss, because they are so apparent. And when you see them in real time, as we see them periodically when we do TEs, see, this would be like a grade 3, very apparent. And notice that then they have little areas there, those things that are flickering often. If you look around, you can see these little flickering things. So the question is, what are they? So X-plane really has helped a lot, because when you put your line right where you are suspicious, you can see very nicely this raised grade 3 atheroma in a corner that if we had done a traditional 90 degree, we might have missed. So this is one of the beauties of the X-plane, is being able to shoot it right there and convert into the longitudinal plane that you will see from there and nicely see that plaque. That is pretty scary. Now those, again, nobody would miss, and you can see look at that, all these linear things that are flying and moving and looking like flying objects. Sometimes we have called them, that in particular. So this is one area where I think, because of the resolution quality combined with the time resolution, TE continues to be the gold standard. And you can do 3Ds if you want to show pretty pictures, but I think the 2D does a pretty good job on its own, with the X-plane particularly. These are just more examples, so you can see all the different variations that you can see. Not uncommonly, these people are in their late 70s, 80s, but we have seen a few late 50s and early 60s with this. So it all depends on how bad your genes and your atherosclerosis and your aorta has been. This is basically atherosclerosis, disease of the aorta. The question is, what are the flying objects? Okay, this is another 3D of this particular one here. You can see it there nicely. I think this was done by you, Steve. I think I took it from you. Yeah. So 100 years ago, well, not quite, but in 1997, when Dr. Selby was a lot more younger, this was a classic study, because this was a study that Nathan, who is now a grandfather, was one of our fellows, did, where Dr. Crawford, I believe, was still alive, and when we made these diagnoses in the TE room, he was kind enough to let us see what that was and send to pathology, and they were all thrombus. So, 99. If you want to say the rule of 100, the rule of 99.9 is that when you see these flying objects, they're thrombus. So you would say, great news, we can anticoagulate and cure them. Well, actually, it has been very disappointing. A lot of the trials that have been done with these lesions have not been very good. Whether you use warfarin, whether you use platelet inhibitors, whether you randomize to different trials, different things, the outcomes still are not great. Patients still have recurrences of embolization. We had one case I can remember, maybe Bill remembers the patient better, but I remember that was one case, this was so horrendous that the patient went for a thoraco-abdominal replacement. It's the only one I can remember. And I mean, it was truly horrendous. And the patient had already had a series of embolizations, and we sort of said, like, I don't know what else we can do. So she had the aorta replaced. I mean, I don't even remember. I don't think we even wrote it off. We just did it, and it stayed in the archives of Methodist Hospital. But it just shows you the frustration that sometimes you go through when you take care of some of these patients. So TEE clearly is the gold standard for diagnosis, but the unfortunate thing is that we don't have really any great treatments right now for this condition. Right?
Okay, so thank you, Dr. Q. I will present the CT-CMR version of aortic disease. This is going to be a whirlwind tour of the aorta. Some things that I have learned, just going over mostly, all the worst pathologies of aortic disease. It's going to be very CT heavy, and the only reason is CMR will really provide the same types of images. So yeah, I just chose one modality and kind of ran with it. Okay, so just I'll out of curiosity, introduction to aortic diseases, it's really the largest artery in the human body. Pumps up to 200 million liters of blood in an average lifetime. We have a wide variety of clinical scenarios that patients can present with, which can be acute or chronic. But some of the things that I will be discussing are aortic aneurysms, dissections, all the acute aortic syndromes. I won't be discussing inflammatory diseases, and I'll mention one congenital abnormality. But main thing to know is this is really becoming more prevalent in Western countries, the awareness of aortic diseases, and it's thought to be because of advanced imaging modalities which can now detect a lot of these diseases, as well as the longer lifespan.
Quick question. Maybe we can get this is a bit bigger for it. So the discrepancy in multimodality in terms of how you do the ascending dimensions, leading edge,
Yes.
internal.
Yes.
What is the guideline and why is there a difference?
Right. So I'll come to it. Okay. It's coming in a few slides, and I'll show you exactly how we do it. So, Dr. Q, the slide's for you. Echo, you really don't see anything unless Dr. Q does it. For the aorta. He's gone. All right, so CT and MRI, right? What are their advantages? Look, you have wide coverage. You can see the entire aorta, including its branches. We have superior image quality. You can take both these data sets and reconstruct it, both 2D and 3D, in any orientation you want. And as well, you can assess extravascular structures. So, so just to get into it, we have to know a little bit about anatomy, so we all talk the same things. This is the aorta, and it's divided into specific segments. And when we make measurements, especially in CMR, we're very particular to make these measurements in the same location. So the ascending aorta is really is defined from the aortic root all the way to the brachiocephalic trunk. It includes the aortic root and the tubular ascending aorta. The aortic arch is from the brachiocephalic trunk to the left subclavian. The descending thoracic aorta is from the left subclavian down to the crux of the diaphragm for the aorta. There is a segment in the descending thoracic aorta called the isthmus. The isthmus is defined as that region from the left subclavian artery to the ligamentum arteriosum. When it comes to aortic diseases, if you look at our CMR reports, all of these measurements are there. These are very standardized measurements. There are some normal variants that we should know about. A common one is the bovine arch. These are just some normal variants I'll mention. One that I was not aware of, but I have seen several times and had to learn a little bit about, was the ductus diverticulum. This is really a remnant of the ductus. I'll show you a case of transection of the aorta. It looks very, very different. This is very smooth margins. There's no irregularity or thrombus, but this is a normal variant. And there's another normal variant called a pseudo coarctation, where you really have an unfolded aorta with redundant aortic tissue. Of course, the arch anatomy gets much more complicated than this, and especially in our congenital heart disease patients, and this is a lecture in of itself. So what do we know about the aorta? Well, there's been a lot of slides coming up just about measurements. And what we know is that usually the largest measurement is in the ascending aorta, and gradually tapers downstream from there. So if you look, the middle line is really your mean. The number that, apart from the aortic root, where the sinus of Valsalva is generally 3.7, 3.8, the normal aorta is around 3 centimeters or less. That's the best way to remember numbers. This is a table of measurements of how, of what are normal by the guidelines. You can see a lot of these measurements were made by CT, and we'll go specifically over. The talk may be over. Okay, thanks. Okay. Yeah. I don't think he liked that one slide of mine. Okay, so a lot of the confusion in the literature when it comes to measurements, from what I was reading about yesterday, is a lot of these measurements, even though it says the method of measuring was by CT, these were based on axial measurements, or even a lot of measurements have been from chest X-rays. So, from a very recent publication that I read yesterday, a lot of confusion of what normal values for the aorta really may not have been very firmly established because they have not been measured in the way that I will be presenting to you in the upcoming slides. But in general, this will give you an idea. You know, the normal root is between 3.7, 3.8, and the rest of the aorta should be less than 3.
So is this outside?
Yeah, well, this is external to external. Yeah. Okay, so when it comes down to aortic measurements, there's a lot of factors that go into place. It varies, you know, based on age, sex, body size, where you make these measurements, obviously, and the robustness of the imaging methods you're using. If you look here, if you look at normal ascending aorta measurements, you can see that as we age, it is a normal phenomenon for the aorta to measure bigger than a person who's young, and you can see that for normal descending thoracic aorta measurements as well. Of this, I don't know.
To be honest, I'm really surprised with that. Is that the average? 4.5 being the average?
That's the high. That's the high. The highlighted one, the red and the blue, are the means.
So I'm old enough. I am old enough to have lived through the times when we thought a 75-year-old with a blood pressure 160 was okay because they were just old. And later we found out that they had bad things happen. So do we have any studies knowing whether those people with aortas of 45, if you were to follow them, they have any worse outcomes or not? I mean, can we really call this normal? I guess is what I'm saying.
Yeah.
We learned the lesson with blood pressure. We thought it was normal until people did some really good epidemiologic studies showing that they were having stroke, having problems. So can we call this normal, or until now, let's say for now, they're normal?
I think it's a great point, Dr. Q. This data, I need to find out what the population was that they were studying. Were these, you know, people without hypertension?
80-year-old ascending aorta, I don't think it's 4.5. At least from our own,
Yeah.
our own data. You have no
Yeah.
data.
These would probably be all, because this is old data, it's probably axial measurements, yeah. But again, 4.5 being the, 2 standard deviations above. We also know that BSA makes a big difference. Here's just some measurements of looking at a person's BSA and just looking at the size of their sinus of Valsalva. So, just another factor. When it comes to measuring the aorta, it's very, very important, especially for CT, not much as an issue with MRI, that we gate the thoracic aorta in order to make accurate measurements. Great example is on the left side of the screen. If you don't gate, you get a lot of motion. This motion is called a pulsation artifact. It can be easily mimicked for an aortic dissection. You gate the images, you're able to clearly see the boundaries of your measurements. Now,
Most CT by radiology
is not gated, and and they keep on. One, from my experience, is one, they're very uncomfortable with the EKG rhythms, and number two, they feel that it increases radiation dose, and that they're very comfortable reading around these artifacts. They recognize them. So, but when it comes to, I think, serially following measurements, you really have to. And there's no doubt been cases where people have been referred to this institution with dissection, and the study's ungated. You repeat a CMR, and there's nothing there.
On that note, again, I think back on the same time that I showed you that data of the aortic debris, there was another study that Dr. Sontag did in another one of the fellows where, again, it was a proper visualized. And we measured the aorta in the segment that the surgeon was to look at. And then the surgeon measured the calipers, which is the outside to outside, okay? And all we had in those days was OCT and radiology CT. CEE, deep radiology CT, got nobody CT nodes that were all over the place. Okay. Despite their claiming that they can work on the other, they were all over the place. Yeah, it was most cases right on with the search engine. Now that was again before we had now before we had.
Yeah, I mean, part of the reason for that is radiologists just report active evidence. They don't reconstruct the aorta and turn it into a cross-section. And the one thing you find is don't do that. If you just report active evidence, you may overestimate the size of the aorta.
And I'll show you an example of that. So the conversations has alluded to the fact that how do we make measurements by CT? We use what's called an MRI. We use the double oblique method, where you really create a short axis view by going perpendicular to the flow of blood in using two other views. And then the measurement is external to external. And this, theoretically is exactly what, like as Dr. Q said, is what the surgeons measure when they put their caliper on the aorta. This is so important to do it this way, and this is a great example of this. If you were to do a simple, in a very tortuous aorta with a lot of disease, if you were to simply do an axial measurement, here I can get 11.8 centimeters. But if you were able to really do the double oblique method, where you go perpendicular to flow in two views and create a true short axis of that area, of that particular segment, the measurement is significantly smaller. So when you're not making measurements that are using the double oblique method, you are overestimating.
Decisions for intervention are made on outside, right? Outside board as opposed to inner board. Correct?
Correct.
Which is based on CT.
It's based on CT, yeah. Absolutely.
So why the difference with echo? Or is there a difference?
I mean, echo, my understanding is you're doing leading edge to leading edge, right? So you're not getting the back.
That old study, we also found the best relation with the surgeon doing outside thoracic. So we actually tweaked.
So the 2016 echo guideline is what? Because it's confusing. Because there's the HAACC thoracic aortic guidelines 2010, and they very clearly spell out echo is inner to inner. Most of the TAMR literature is leading edge to leading edge, whereas the CT is external to external. So what's the chamber dimension echo guideline today?
I think the problem with echocardiography is that's why you use an inner or leading edge to leading edge, right, or inner to inner. Is most of the time the trailing portion of a structure is very difficult to decide where it is. What I'm talking about is you have the anterior portion of the aorta, you have the posterior portion of the aorta. The measurement is not a problem in the anterior portion. I can define the anterior surface, I can do this one. The trailing edge of this one is the most difficult. And that's why you go either leading edge to leading edge, meaning that you bypass this issue, and you still underestimate by the thickness of that posterior aorta. Or you go inner to inner, and therefore obviously you make even worse. For clinical decision making, you'll make even a smaller measurement. So ultimately, when it comes closer to decision making, right? I mean, and remember, these are not hard rules. They are very. You'd like to see a CT or an MRI to truly look at the 3D dimension and that outside world. But this is the issue with ultrasound. If you see them, to me, if you see them well, I would measure outside to outside. But most of the time, you may not, and then you don't know where that number is. Yeah, it's interesting. It's sort of amazing. What did the new ASC aortic guidelines say?
I think it's the chamber dimension guidelines, right? The echo
No, there's aortic guidelines in 2015. Both aortic. They actually have a nice paragraph in there saying the committee hopes to try to resolve these differences, but was unable to, and therefore recommend echo continue doing the way it does and MRT continue to do the way it does. But do you understand? You're not going to be able to resolve it. You really are not. In the best situation, you will take away the thickness of the posterior wall or whatever that grade is.
Yeah.
That's in the best situation.
So that would predict that echo is usually
stick with the same modality.
The one issue with that is if you have a lot of atheroma, that's when echo is significantly underestimated. Because the wall may not be just 2 millimeters thick, and it's much thicker, right? But you can't really tell that. So
I think it's mostly an
comes
issue.
into play is more of an issue. In the ascending aorta, it's not much an issue, because you don't have a lot of atheroma in the ascending aorta. But in the descending is where the sizes become quite substantially different based on outer dimension versus inner.
From a practical point of view, what I've done with the two patients I'm following is I get CMR or CT or I do CMR model. The same timing with the first assessment that is then establish sort of your own internal height.
Yeah.
And then you go to one or the other, you know which of the two numbers is to follow.
Or stratum.
That's one we accept another.
Yeah, what I think, as soon as I get close to a decision point, you're getting up to,
Yeah.
flat 3, then I'll just stick to one modality. That way the 1 millimeter difference is just,
Yeah. That is.
but if it's 4, it doesn't matter.
Yeah, that makes sense. So this is just the guidelines from the thoracic aortic guidelines. Again, just hitting the main points that I hoped I made was that you want to make these measurements at reproducible landmarks. You want to do it axial to the flow of blood, and you want to measure external to external. One of the things, like I told you, this is going to be a potpourri of the aorta. One of the things that I wanted to mention is what is the definition of an aneurysm? We hear the word used all the time. An aneurysm, by definition, has all 3 layers, intima, media, adventitia, but it's defined by a 50% increase compared to the normal diameter. So if your ascending aorta normal diameter is 3.7, 3.8, you use the word aneurysm when it's 5.5 centimeters.
So we use it way too much.
Yes.
I'm sorry, but I don't know. Because again, it goes back to what Dr. Q was mentioning. I mean, if the concern is, right, an increased stress and the propensity for rupture, I'm not sure what the normal tells us, right? But what the standard deviation of the difference between, unless, you understand? If the concern is that, then I don't have it with you. Normal diameter is not the upper limit of normal for the population. It's the normal for that patient, right? So, don't take the upper limit of normal and say it's got to be 50% more than that upper limit of normal. That's not necessarily correct.
Yeah,
But that's a number you don't know.
you don't know what the normal is.
Yeah. I think what we're trying to differentiate is between what is a number where maybe prognosis changes, and I have some slides on that. But that's, again, only relevant if the patient has a smaller sized, body surface area. I'll show you some. I have a slide on that. Whereas if they're very big, then I think those variables get confused.
It's okay to normalize for body surface area or height. Body surface area is an issue nowadays with obesity and everything else. But I would still think about the absolute number because we don't have any other measure, a better measure of stamina around surface.
I'll get now into a little bit about aneurysmal segments of the aorta. So the first part is, of course, sinus valsalva aneurysms. This is a great example of one. Most commonly affected is the right coronary sinus, followed by the non-coronary sinus. These can protrude into the RVOT, obstructing them, or they can, as in this picture in C, where you see the blush of contrast, these can actually rupture into the right heart, be it the right ventricle or the right atrium, and lead to shunting. They can also cause cardiac tamponade if they were to rupture into the pericardial sac. So let's talk a little bit now further up on the aorta, thoracic aneurysms. This is really the 18th most common cause of death. It's predominantly a silent disease, and it's growing in incidence as we discussed. And one of the things we should know is that people who have thoracic aortic aneurysms, especially ascending thoracic aortic aneurysms, there tends to be a very strong genetic component. And maybe this is a slide that the fellows should go over at least before they sit for their boards. There's very specific genetic defects with some of the common genetic syndromes, such as Marfan, Loeys-Dietz, and Ehlers-Danlos. And this is just another slide showing that along with these, thoracic, these patients have what do you call it, clinical features that can help you make the diagnosis. Now, what's interesting is disease in the ascending, in the thoracic aorta is different, whether it's ascending or descending. Disease above the ligamentum arteriosum, or ascending aortic disease, tends to be non-atherosclerotic, or its etiology is medial degeneration or the elastin fibers in the media, and again, this is usually with some sort of congenital or familial or genetic abnormality. Whereas below the ligamentum arteriosum, or in the descending thoracic aorta, this is an atherosclerotic disease. And so here's just an example of an ascending thoracic aorta. This is what you not only do you see the ascending aorta markedly enlarged, but you also see that the aortic root is enlarged. You see effacement of the sinotubular junction, and this would be an aorta that can be very consistent with a patient with Marfan's. Other familial conditions that can cause associated aortopathies include bicuspid aortic valves. Here you can see, in systole you can clearly see this is a bicuspid valve, looks like a football, and you see the associated dilation of the ascending aorta. And this is just a recommendations that those patients who have with bicuspid valves should have first-degree relatives screened. Now, what's interesting, this is a graph looking at risk of complications with thoracic aneurysms. And what's good to know is that, these complications really can occur at any size, but really the takeoff where you have the most complications starting is around 6 centimeters. And this is just another graph also highlighting that point. If you look at the ascending aorta, really where the risk of complications really jumps, it starts at around 5.5 and really takes off after 6 centimeters. Descending aorta is a little bit, in the ascending aorta starts around 5 and really takes off after 6. In the descending aorta, around 5.5 and then really takes off after 7. This is a slide going over just some prognostic data, looking at patients who have different sized thoracic aneurysms, what their outcome was. Obviously, it makes sense. The bigger the aorta, the worse their prognosis. But this is the slide that... Yes?
Just to see so it's only 5 years.
Back in 1999, yeah.
Now, this is just straightforward biopsy happening. It doesn't tell you what they are dying.
What their etiology is or what they're dying
So it
from now.
could be that a 4 to 4.9 is not treating them because they rupture, but it may be a marker of more other diseases and they're dying from an MI.
Absolutely.
Whatever else.
Absolutely.
Yeah. So that, be careful with how you progress. That doesn't mean that, because 4 to 4.9 already is kind of scary compared to 3 to 3.5 by 5 years only.
Correct.
So the question is, what are they dying from?
Right.
Did they actually throw in any light into that?
I will go back and look at this one in particular. But you're right, this is just a retrospective study. But
Remember also, this is not a static tobacco. Yeah, and you look at data like these, you have to think of what's the history within the next ensuing 3 to 4 years of that 6 that started like that.
Right. Oh, yeah, absolutely.
So, it's not a static momentum. It's a progressive, not continuous. And you just wonder even the ones between the 5 and the 6, or the 4 and the 5, whether some of them progress much faster than others.
very good points. And this is, I think, what point that the table that I was referring to earlier in reference to Dr. Zogby's question was, I think this is probably a little bit more helpful where, if you have a normal-sized individual, there are some prognostic data where you can take the patient's aortic size and index it to their BSA. And I've put in the bottom, you become moderate risk, which is about 8% per year when you're at 2.75 centimeters per BSA, and you're severe risk when you hit 4 centimeters per BSA. Now, obviously, this may not be helpful, in the Texas population where you have very morbidly obese people. But if a patient, especially on the lower spectrum and low spectrum BSAs and normal BSAs, this can be helpful.
Yeah.
Yeah.
Maybe a better
absolutely, yeah.
It sounds like a very logical thing that you suggest, right? Have anybody actually done it?
Yes, I can recommend it to the guidelines.
Fine, recommend it, but anybody has done anything, like this, longitudinal data, risk calculation, stuff like that.
Yeah, I'm not.
Because other than that, it's an attractive theory, but if you don't have the actual data, then you don't know what are the cutoff points and everything else.
Yeah, I'm not aware.
It makes sense, but it's nice to have them some theory. What would present a number that you report?
Is there any prognostic significance for an aorta that gets longer? The length from the root to the renals, because we know that aorta is on hold. That's not just patients getting shorter. That's actually they don't just get bigger in one dimension; they can get bigger in length.
That's a good question, Steve. I have not seen that.
With CT, you could easily do a center line.
All right. Who wants to take that on? We should try to do that, huh?
I believe so, absolutely. If we have serial imaging.
You have to do subsegmental measurements and then add them up.
It's
doable. But I don't know.
It's interesting,
What
yeah.
you can do it. The question is, if you do it, what question would you ask after you have made the measurement?
How does it relate to some of the other measurements? Yeah. So when it comes to recommendations to patients with ascending aortic aneurysms, I guess for board purposes, when do you refer to surgery? Normally, if the patient is symptomatic, if they have a size greater than 5.5 centimeters, or if they have a growth rate greater than 0.5 centimeters per year. If you have a situation where you have a familial condition or a syndrome or an aortopathy, then the recommendations for surgery are much earlier at a size anywhere from 4.5 to 5, depending on how strong their family history may be. Okay, so this is, again, now moving along the aorta. We're now talking a little bit about coarctation. Coarctation is another talk that really, one slide doesn't do it justice. But this is a classic location. It's caused by a focal narrowing in the thoracic aorta, most commonly at the isthmus. It's a fibrous ridge. And we usually use the left subclavian artery to help us distinguish between subtypes. And one thing, it's very important that if you do have a patient with coarct, you can see in the CT data set how you can see collateral vessels, because blood has to get down to the legs, and usually it comes, from collateral vessels. But it's also very important to evaluate these patients for intracerebral baryaneurysms. Okay, so the final part of this talk is, other insults to the aorta is acute aortic syndromes, and this is really where we're going to spend most of our time. You should know that these are really all a related spectrum of diseases. They have a common clinical presentation. They frequently have common risk stratification and common therapies involved. Most commonly their incidence is about 3 out of 5 out of 100,000 patients. Most common are aortic dissections at 72%. IMH follows at the next third, and a smaller degree are the penetrating aortic ulcers. Most common symptom is acute chest pain. However, because could potentially involving branches of the aortic trees, you can present with all sorts of symptoms, including neurological symptoms, syncope, acute stroke symptoms, acute myocardial infarction, abdominal pain, peripheral neuropathies, paraplegia, cardiac arrest, sudden death if they have cardiac tamponade. So it's really a full spectrum. We really should think of aortic diseases when we see catastrophic illnesses in our patients. What are the goals of imaging? Of course, it's to confirm the diagnosis, make measurements, classify, localize, assess the extent, look for branch vessel involvements. Is there viability of the end organs, and rule out any concomitant life-threatening complications. Now, just a quick word, how do you choose between CT and CMR? We all know the strengths of each modality. CT is faster. Patients, because of that, may prefer it. It's available in every emergency room. and it really doesn't have any problems with metal. Cardiac MRI has the advantages of tissue characterization. It also provides functional hemodynamic information similar to echo. You can use it in patients who have iodine allergies. We can use ferromoxetol in those who have a GFR less than 30. And one thing that's very important in choosing is if you have young patients or pregnant patients or patients you're going to be following with serial imaging for many, many, many years, definitely CMR has a strength there without repeated radiation insults. So aortic dissection. What is an aortic dissection? Aortic dissection is really an intimal tear with a resultant propagation of blood, systolic blood into the media of the vessel. It's the most common cause of acute aortic syndromes. About 66% tend to be male, elderly men, and 73% involve the ascending aorta. Of course, as we heard Dr. Q say, outcomes vary depending on your type, location, and presence of complications. But in general, it has the highest mortality. With the ascending aorta, we've all heard this, where you can have a risk of 1 to 2% per hour over the first 24 hours. So really important to make the diagnosis quickly, get these people to the operating room quickly. There has been some series, I've seen numbers all over the place, but in general, if a patient is inoperable, they have a 58% of death, in-hospital death, and if you operate, mortality comes down to about 12%. If for the descending aorta, again, if it's is also not without its risks, a complicated aortic dissection there has a risk of almost 20%, whereas it's 6% for uncomplicated diseases. Most common causes are hypertension. There are a risk. There's tables of most common causes of aortic dissection, or you can really use the same table for any of the acute aortic syndromes, and it's very much linked to medial degeneration. And this tends to occur most commonly in patients with cardiovascular disease, so patients who have hypertension, or those who have connective tissue diseases, as we had mentioned. We talked a little bit about the DeBakey and Stanford classifications. This is just a quick slide to show that of all the type A dissections, we often hear that the aorta has to be enlarged, but this is a nice table that does show that in this one particular study, the mean was 5.3, but aortic dissections did occur in smaller aortas. Now, unenhanced, when it comes to CT, we always think, contrast is going to answer all the questions, but when in aortic dissections, actually, a non-contrast CT can be very helpful. And one of the ways our first clue that you may have an aortic dissection is when we see calcium floating in the center of the vessel. And what this calcium suggests is that the intima has torn, and now you have two potential spaces. And I'll show you an image of that. So here's an image without the contrast, and here's an image with contrast. And now you can clearly see that this piece of calcium that was floating in the middle of the vessel is really a piece of the is part of the intimal tear. Contrast that to someone who has a normal aorta without a dissection, which may have mural thrombus. You can see all the calcium at the periphery of the vessel. Contrast-enhanced CT with cardiac MRI can provide a lot of useful information, and it helps you make the diagnosis. Classic findings are the double-barrel lumen, which represents the true and false lumen separated by the intimal flap. We can identify entry sites and exit sites, and at the same time identify dilations and sizes of the aorta. Determining false lumen and true lumen, we have a lot of features that can help us. In general, the true lumen is the one that's communicating with the flow of blood through the aortic valve. Other clues that can help us is, usually the larger is the false lumen. The false lumen will have slower flow, it'll be less enhanced. If you see shredding, as demonstrated in some of these images where the star is, usually that also, it's called the cobweb sign. It's where the intima has sheared. That's also a sign of the false lumen. And then there's wherever you have very tight angulations with the aortic wall, that's called a beak sign, also suggesting the false lumen. When it comes to assessing complications, of course, this is a 3D technique and with a large field of view, we're able to look at the carotids, we're able to assess, all the different arterial beds and branches coming off the aorta. Other complications that we can look for are, as we had mentioned, if there's any evidence of blood within the pericardium, we have to be very concerned about impending tamponade. You can see the dissection flap, and you can look for involvement of the coronary arteries, and in this one picture on the right, actually a hemithorax. MRI can also be very helpful, and a lot of the one, you can determine the chronicity of your dissection. A flap that's very highly mobile suggests acute nature, whereas if you have a dissection if you have a flap that's immobile, suggests a chronic dissection. And then looking at the flow in the true and the false lumens. In general, if your false lumen has not thrombosed, it is a marker of a worse prognosis, and the reason being is, it's pressurized and therefore can continue to expand. CMR can also be very helpful in identifying dynamic obstruction, and dynamic obstruction is really when the false lumen, if it is pressurized, goes and occludes one of the mesenteric vessels or renal arteries during systole, or during some phase of the cardiac cycle. So this is one older study which actually looked at the 3 techniques and their predictive abilities into diagnosing aortic dissections, and really, CT and CMR both fare very, very well. TEE does well as well. In an older study, it seemed to have it was less specific. Intramural hematoma is really a bleed within the media, usually caused by a rupture of the vasa vasorum. There is no flowing blood. It's about, again, 20% of acute aortic syndromes. Its predisposition really is females, and typically involving the descending aorta. It has a variable clinical course, but I think what to remember is about 1/3 will resolve, and patients where it's more likely to resolve are those who are younger, with smaller aortic diameters, smaller hematomas, and maybe those on beta blockers. Of course, the other 2/3, unfortunately, go on to suffer complications, including aneurysm, rupture, or progression to dissection. When it comes to CT making the diagnosis of intramural hematoma, it's actually, again, the non-contrast CT that's very, very helpful. And here, because this is acute blood, this tends to be a hyper-attenuating signal, and actually appears as a crescentic shape on the outside of the wall of the aorta, which does not spiral. Notice, when to give contrast, it actually can be a little bit more difficult to see now with CT, but the main clues are no enhancement after IV contrast, no intimal tear identified, and no spiraling. With CMR and the ability to use our tissue probing techniques where we can actually identify thrombus, it can be an easier diagnosis to make.
But you look also that you see an eccentric increased frequency.
Correct.
So that your eye should catch that.
Your eye should catch that, yeah.
But the picture you show was very impressive that without the contrast, actually, you see better.
You see it with that better.
Yeah.
And actually, Dr. Kia, I wanted to ask you, I have seen a lot of, when I'm doing TEs, I shouldn't say all of it. I have seen this during TE, and I have, a patient that has no symptoms or no indication for that. And I've often thought it was fat on the aorta. Have you?
Well, yeah, but neurothrombus
It's on the inside.
because inside is inside in lumen. But what you say, I'm assuming that you're saying that you have seen with TE something that is outside.
You see outside, and it's this thickening that you see, and I get nervous.
Sometimes you can have aortitis. I've seen some cases that are amazing.
the wall. So the lumen size is fine, but just when you measure from the outside, and you just don't know what to do with these people. Because surgery is not your best bet.
Well, those people with something like that?
Yep.
Okay. This is just
Particularly if it is diffuse. This is not focal. This is diffuse.
diffuse.
On a big portion of the aorta.
Right.
You can get a PET scan, actually, if it is an acute inflammation, you can see it live positive.
One of the benefits, again, with CMR is you have all these different sequences and how, your findings behave in different pulse sequences. But in general, you'll see a concentric thickening, which really, with no identified intimal tear and no spiraling noted. So there have been, high-risk features of IMH, but basically the more the hematoma, the worse, and the more concerning it is. So finally, penetrating atheromatous ulcers, also known as PAUs. Here, you really have to have atherosclerotic disease. Here, because of inflammatory process, the internal lamina has eroded, and you have a plaque that has ulcerated into the media. Now, it classically, again, occurs in regions of atherosclerosis, with 90% being in the descending aorta. This can go on, again, to progress like the other acute aortic syndromes. It can go on to either aneurysm formation in 27%, dissection, or rupture. And so here are examples. Again, they look like, you see atherosclerosis in each of these images, followed by a mushroom-like outpouching of the wall. Okay, and here's another one. Again, notice its predilection is in regions of atherosclerosis, such as the descending thoracic aorta. And here was an interesting case where you actually had a penetrating ulcer, and also, although the tissue intensity doesn't show it well here, but you had associated with an intramural hematoma going down the descending thoracic aorta. And here's just an example of an image I saw online, which was good, nice to share with, in a patient who had serial imaging. Here you can clearly see, evidence of where the wall should be, and you've got this penetrating aortic ulcer. This patient, went to him to have repeated imaging later on, and here you can clearly see that this is now developed into a saccular aneurysm. So just showing us that, the natural history of this disease. One of the things that I also learned doing my reading for this, and I have, I've made this mistake before, is oftentimes, and it's very important with CT, is we'll often see in a patient who's postoperative, we'll often see very bright signals outside the lumen of the aorta. So one of the importance of this talk is not only to identify abnormalities, but to also understand what normal is. And, there has been one case I remember I called up Dr. Reardon, and I said, Dr. Reardon, I'm not sure, but I think there's extravasation of blood. And he's like, no, the patient's fine, how can it be? And I was seeing things like this all over the ascending aorta, these very focal spots of what appeared to me as contrast outside of the wall of the aorta. And actually, this turns out to be, this is all felt surgical material that they use at anastomotic and cannulation sites. So this is just a normal post-operative aorta that you can often find. Now, other worrisome findings, thank goodness we haven't seen too many of these, but if you're going to have an aortic transection, the one that tends to survive, although they all have high mortality, is the one that occurs at the isthmus. It is a sudden tearing of all three layers. It's usually caused by a rapid deceleration, usually a motor vehicle incident, or falling from heights. And what you'll classically see it in this location, and what you're seeing here is, just complete transection of the aorta, and with intraluminal thrombus forming. And obviously, if this is not taken care of, this can be a very lethal disease.
Basically, whatever fibrous tissue is containing the aortic pressure.
Yeah, is holding the aortic pressure inside, yeah. When it comes to medical therapy for any aortic syndromes, the most important is aggressive blood pressure control, You want to aim for blood pressures at 100 to 120. You want to use IV beta blockers as the first-line therapy to reduce DPDT. Opiate analgesics are also important to blunt that catecholamine response that you get. Treatment is, of course, dependent on the location of the acute aortic syndrome. If it's a Stanford A, involves the ascending aorta, generally this is surgery. And if it's Stanford B, this is where it's involving the descending, this is generally medical therapy, unless there is end organ malperfusion or the development of complications. This is again there's a lot of charts out there making recommendations, but once these people have had some sort of aortic surgery or aortic abnormality, there is periodic interval reassessment that is recommended by the guidelines.